This is a brief video about evaluation of decisional capacity in palliative care. I'm Dr. Susan Merrill. I'm a general internist and geriatrician practicing at the University of Washington and Harborview Medical Centers in Seattle. The objectives of this video are as follows: to describe the importance of decisional capacity assessment in palliative care, to identify the 4 abilities related to decisional capacity, which is synonymous with decision-making capacity and which I will sometimes abbreviate as DMC in this video. Describe when and how to assess and document decisional capacity at the bedside. And lastly, discuss ways to best work with the surrogate decision makers when patients lack decisional capacity. First, I'll define some terms. Decisional capacity is the ability to accept or refuse care, essentially the ability to provide valid informed consent. It is closely related to, but not the same as, competency. Decisional capacity is decided by clinicians at the bedside. Competency is decided in a court of law. Informed consent is acceptance of a medical intervention after disclosure of the nature of the intervention, risks and benefits, and alternatives with their risks and benefits. Informed consent must have 3 elements in order to be considered valid. The patient must have decisional capacity, the decision must be voluntary, and enough information must be given that a reasonable person could make an informed choice. There are essentially 3 situations in which you don't need the patient's formal informed consent for treatment: in life-threatening emergencies, when the patient lacks decisional capacity, in which case you must get consent from a surrogate, and when a patient refuses to provide consent, preferring that a surrogate make the decision for them. As you know, preferences about medical decision-making differ across families and cultures, and there are certainly patients who defer to others for their decision-making. We should support that. Why is it important to learn to assess decisional capacity as someone who cares for seriously ill patients and is interested in providing better palliative care? First of all, we are often helping patients make important decisions about end-of-life care, so we want to know whether they are legally and ethically able to make their own decisions, or if we should turn to a surrogate. Second, lack of decisional capacity is common in people who are medically ill. Studies suggest that as many as 25%, 1 in 4, of medicine inpatients and 45% of nursing home residents lack decisional capacity. Furthermore, lack of decisional capacity is under-recognized by both clinicians and family members. Studies of standardized instruments for decisional capacity assessment suggest clinicians only recognize 40% of patients who are found to lack decisional capacity by a gold standard assessment. In one study of medically ill inpatients lacking capacity, their medical team thought they had capacity in over 75% of cases, and their closest relatives also thought their loved one had capacity in over 75% of cases. Of note, clinicians tend to be better at recognizing decisional incapacity when patients disagree with our recommendations. We tend to assume that people who are agreeing with us have capacity. It's important to know that lack of decisional capacity is both common and under-recognized in medically ill patients. You may be referred a patient for palliative care by a clinician who has not recognized that the patient lacks decisional capacity, so you will need to know how to assess this. What are the implications when we incorrectly assume that someone has decisional capacity when they don't, or vice versa? The ethical principle of autonomy would suggest that any patient who can make their own decisions should do so. Next, it's part of our laws as well as medical ethics that we follow rules for informed consent, including ensuring the patient has decisional capacity. Lastly, surrogate decision-making is not perfect, and surrogates may not actually make the same decisions as patients, even when they are instructed to use substituted judgment. There's a study about decisional capacity in palliative care that highlights this last point. Dr. Zaros and colleagues looked at patients with advanced cancer who died at the University of Michigan Hospital. 79% of these patients had decisional capacity on admission, but 40% lost decisional capacity during this terminal hospitalization. Those patients who lost capacity and had a surrogate make decisions had more aggressive care prior to death, including more ICU care, more mechanical ventilation, more chemotherapy, and more artificial nutrition. So if we are able to assess decisional capacity and help decisional patients make end-of-life decisions earlier during a hospitalization before they lose decisional capacity, it may actually change outcomes. So how do we assess decisional capacity at the bedside? We use 4 abilities related to decisional capacity, first described by Applebaum and Grisso in the New England Journal of Medicine in 1988. The 4 abilities are as follows: the ability to communicate a choice, the ability to understand one's condition and propose treatment, the ability to appreciate a situation and its consequences, the ability to demonstrate a thought process that we can recognize as rational, although we don't necessarily need to agree with it. Again, communicate a choice, understand information, appreciate the consequences, and reason rationally. The ability to communicate a choice is the easiest standard to meet. Most patients who cannot communicate a choice, even with our best efforts to help them communicate, do not have decisional capacity. For example, people with very severe dementia who say only a few words. Many experts add to this standard the requirement that the choice should generally be stable over time, which screens out most people with delirium. Understanding is also a relatively straightforward standard. Patients should be able to understand information related to their medical condition and the proposed treatment or other decision they are being asked to make. For a treatment decision, the patient should understand risks and benefits of a treatment and alternatives to the proposed treatment. After information is delivered, the patient should be able to summarize what they have learned. The clinician should use the teach-back method here. This is a test of the clinician and how well they have explained the situation, not a test of the patient. Appreciation is a higher level ability. A patient who appreciates a situation can show not only that they understand the relevant information, but how the consequences of a situation might affect them personally. This requires insight into one's illness. People who have schizophrenia or other psychiatric conditions and do not believe that they have a psychiatric illness may lack decisional capacity for this reason. Here is a sample statement from an elderly patient who is refusing nursing home placement here, which demonstrates appreciation of the consequences of refusing to go to a nursing home. The patient says, "I know I might live longer if I move to a nursing home. I could even fall and break my hip at home, but I've always known I'll take my chances. I'd rather die than leave my home." Reasoning requires some illustration of a rational thought process, although it does not need to be one that everyone would agree with. Patients should be able to indicate the major factors in their decisions and the importance of these factors. There are 2 statements on this slide illustrating rational reasoning. A patient might describe his choice of surrogate as follows: "Jane would be a better decision maker for me than my son right now because I haven't been close to him in years. Jane is like a sister to me, and I would do the same thing for her if she needed it." A patient refusing medication might illustrate their reasoning by saying something like, "I've never believed much in taking medicine, and I'm not going to start now. I've had a lot of problems before when doctors gave me pills." The process of assessing decisional capacity is actually quite straightforward. Of course, because this is an important conversation, you should first make sure conditions are optimized for the patient to participate. If there are communication challenges, consider involving your speech pathology colleagues to optimize communication first. This is particularly important if the patient is intubated or has other communication challenges. Then, you just have a conversation with the patient about the decision and ask them questions that will help you determine whether they have the 4 abilities. Explore all yes or no answers when possible. The more the patient can explain their thinking, the better. I've listed some sample questions for some of the abilities here. More sample questions are available in the 2 review articles referenced below. Two important notes here. Decisional capacity is temporal, meaning the patient can have it one day and then lose it the next day, for example, if they become delirious. Keep this in mind. Sometimes a decision is not urgent, so if you think the patient may regain their decisional capacity as their medical condition improves, you may be able to wait and reassess. It's also decision-specific, meaning a patient can have it for a simpler decision, like choosing a surrogate, and not have it for a more complicated decision, like deciding between 2 complicated kinds of treatment with different risk-benefit ratios. A note here on values. It's important to know the patient's values and how they've lived their lives and made decisions in the past. While this is not included in the 4 abilities and may not be part of the official or legal definition, it's really important in helping the patient and/or surrogate reach a decision that makes sense for the patient as a person. Of course, you would already be learning about the patient as a person and clarifying their goals and values as part of your usual palliative care work. This is even more important to explore with the patient's family when the patient may lack decisional capacity and you will be working with their surrogate decision maker. We are often working with patients and families who are from a different culture or background than our own. There are a few additional considerations here. In some cultures, it is fairly common to have the family make healthcare decisions instead of the individual patient. Sometimes families believe that telling the patients details of their diagnosis could harm them. If a family member tells you this, it's important to confirm this with the patient, but if the patient says they'd like their family to make their decisions for them, essentially they are waiving their right to provide informed consent, and we should respect this. If a patient does not have decisional capacity, their surrogate will need to make the decision. I've included the list of legal surrogates, both for Washington State and for the VA system, which has a different list. As you may know, the guiding principle of surrogate decision-making is substituted judgment. The surrogate should be trying to make the decision they think the patient would make if he or she still had capacity. The surrogate should base the decision on what the patient has told them in the past, if they have discussed this health situation, or can infer the patient's preferences based on their statements, actions, values, or beliefs. When the surrogate does not have enough information about the patient's preferences, such as in the case where the patient's legal surrogate does not know them very well, they may consider the best interests of the patient. In this case, they should make the decision that would best promote the patient's welfare, for example, by relieving suffering and/or preserving function. Of course, the healthcare decisions we ask surrogates to make can be complex, and clinicians often need to guide surrogates through a decision more actively. How is this actually done in practice? Douglas White and colleagues conducted an interesting study of decisions regarding continuing life support in the ICU. They analyzed 162 conversations between clinicians and surrogates and found the following 4 ways of working with surrogates. Informative, in which the clinician provides medical information and it's up to the surrogate to decide. Facilitative, in which the clinician actively guides the surrogate through the process of clarifying the patient's values and applying those values to the decision. Collaborative, this is the same process as the facilitative role, but the clinician also offers their recommendation based on the patient's values for the surrogate's consideration. And directive, in which the clinician makes the decision and informs the family. All of these methods are used by some clinicians. In palliative care, most of us use either a facilitative or a collaborative approach. We modify this based on the clinical situation. Sometimes there's a clearly best answer given the patient's goals, and sometimes there are a few reasonable options. The directive approach is used very rarely, most often in the case of a family requesting care that we think is medically futile. Karlowich and colleagues described an approach to working with surrogates of seriously ill patients that combines the facilitative and collaborative approaches. They conceptualize this as a dialogue between the surrogate and clinicians. The goal is to reach consensus about the diagnosis and prognosis and the benefits and burdens of treatment options. The clinician helps the surrogate make decisions based on substituted judgment and/or the likelihood that a given option will help reduce suffering and/or maintain quality of life. This is the model that most of us strive for. In some cases, you may want the patient's assent, essentially just their agreement with the course of action, even if they do not have decisional capacity and a surrogate is going to give informed consent. This is often the case for a relatively burdensome procedure such as an amputation. This is important to keep in mind as you reach consensus with the surrogate about the best course of action. If a surrogate is considering a burdensome, life-sustaining therapy for their loved one, they may need to consider that the patient might refuse something even though they are not decisional. The surrogate may not want to proceed with a therapy that their loved one will resist. Documentation of assessment of decisional capacity is relatively straightforward. Document the conversation with the patient as clearly as possible. You want to document evidence that the patient does or does not possess each of the 4 abilities. Use the patient's own words when possible. It's important for clinicians of all disciplines to be able to do basic decisional capacity assessment, but the psychiatrists are the experts. Palliative care clinicians should consider consulting psychiatry when we are having trouble deciding whether the patient has decisional capacity, when the patient has poorly controlled psychiatric illness, and when there is conflict between surrogates, teams, or teams and surrogates. Thank you so much for your attention. I'm happy to answer questions by email. These are the articles discussed in this video. These are the rest of the articles.